So, Assalamu alaikum, everyone. My name is Mariam Hussein. I'm the current Vice President of IMANA, and I'm also working with Dr. Umber Khan, who's also on the webinar as well, too, on IMANA's Education Committee. So I want to welcome you all to the continuing series that we're having about education. And our topic this evening, inshallah, will be about pelvic pain. So without further ado, we're going to get started. I'll go over some logistics and everything as well too, inshallah, as we move forward. So Bismillahirrahmanirrahim. So Assalamu alaikum again, everyone. So our topic for this evening's webinar is taking the stigma out of pelvic pain. So we're very pleased and fortunate to have our speaker, Dr. Tayyaba Ahmed. She's going to be discussing the basics of pelvic medicine, from what the pelvic floor is to common pelvic diseases and their treatment, including vaginismus, endometriosis, chronic pain cycle, and infertility. So Dr. Tayyaba Ahmed, she's a doctor of physical medicine and rehabilitation and out of New York Institute of Technology, and she was trained at New York College of Osteopathic Medicine. Actually, she's done a lot of work in this field. She's a contributing author to a textbook, which is considered a staple during every physiatrist training. And the 4th edition has been published in November of 2018. And so just for everyone to know as well too, this webinar is being recorded. So if you have to leave or need a review later, feel free to. And in terms of questions and everything, so there's an option on the GoToWebinar control panel to ask to type in questions, since all the attendees are in listen-only mode. So please feel free to type in any questions that you may have, and we'll address those at the end of the webinar, inshallah. We should be done around 8:30, just as well too. So without further ado, I'll hand it over to Dr. Ahmed.
Okay. Mariam, thank you so much. Let me know if this looks good. Ready
Yes.
to go? Okay, perfect. All right, assalamu alaikum. So I am going to talk about pelvic pain and taking the stigma out of it, because as predominantly a lot of Desis, Pakistani, Indian, Bengali, but to be completely honest, it's even within among Caucasian families that there is a lot of stigma with pelvic pain. So first, I'm going to explain what the pelvic floor is. I dragged all of my stuff through Manhattan, so I'm going to use my models that I brought from my office. The pelvic floor is an area that is between the pubic symphysis, which is the bone in your front, and the bone in the back, the tailbone, also known as the coccyx. When women give birth, there is often sometimes pelvic, the bones can separate, the pubic symphysis can separate. There is a normal amount of pubic symphysis inflammation called osteitis pubis, but not everyone's actually goes back, which should happen. The pelvic floor is between that pubic symphysis and the tailbone, and I call it a pelvic bowl because it's not exactly just a floor. With my patients, I do go over all of the type of the muscles. So essentially, between the pubic bone and the tailbone is the bladder, the uterus, and the descending colon. And it holds up these organ systems. And in many women, it's nice and strong. And I often say when you're normal, it's at a 0. And when it's too loose and it's weak and the muscles are kind of loosey-goosey and weak, and you typically hear about your grandparents who are in Depends diapers, that's a hypotonic pelvic floor. And when they're tight, and you may have spasms in your pelvic floor, that's a hypertonic pelvic floor. So if these muscles are really tight, you have trouble with urinating, having passing bowels, so you might be having chronic constipation, and then pain with intercourse. In the situation where it might be loose and hypotonic, that's when you typically see a prolapse of your uterus, of your bladder, or of your rectum, and that's when your pelvic floor. So in both scenarios, the pelvic floor is in fact weak. It's just presenting either hypertonic or hypotonic. And so, basic terms, the pelvic floor, and I'll show you other pictures, between the pubic bone and the tailbone, pubococcygeus, puborectum, puborectalis, and then the iliac bone to the coccyx is the iliococcygeus. The pubococcygeus and the iliococcygeus make up the pelvic floor. The term levator ani, which sometimes when you Google pelvic floor, you hear the term levator ani and you don't know what it is. Basically, pelvic floor dysfunction is having something wrong with your pelvic floor, whether it's the tight or whether it's the loose. And so there are ligaments, and those are the muscles, but there's also bones. And so I'll kind of go over, well, I may or may not go over this, but sometimes patients will present with pelvic floor pain or pelvic pain because they're having those tight muscles due to a fall on their tailbone, and their tailbone muscles are now, that are attached to them, now tight. They may be chronic spinning, people who love to go spinning, or it could be after childbirth. It's not, a lot of people think that all I see is post-childbirth, and then that's obviously not the scenario. I do see a lot of endometriosis and vaginismus and trauma, and I also see males. This webinar was mostly designed for women, but I do see males. About 40% of my practice is males, and that typical scenario with males can be after some trauma due to intercourse, or even just sitting for 12 hours at a day. A lot of people, you know, they don't take breaks, and just sitting on their muscles can affect their nerves and then cause pain. I very rarely even talk about hypotonic muscles, because typically hypotonic muscles don't even cause pain. And so most people who are desperate usually don't go to a doctor for something that doesn't cause pain. But that being said, there is a need for women to, and men, I guess, well, yes, definitely men, not to leak urine. So that classic grandfather or female at postpartum who's having urinary leakage, the hypotonic, there is this prescription-based tool called the Leva. I mean, if your doctor has to prescribe it, or your pelvic physical therapist, you could go to pelvic physical therapy, which is definitely helpful and useful, but a lot of people don't have time for that. So the Leva is actually a tool that I brought here just to show you. It is interesting because it attaches to an app. You put this in your vagina and you use it and hold for 2.5 minutes. So I'm going to see if I can show you what it's supposed to look like. Let me know if you can't see this, but the Leva is placed inside, and when you're lifting properly, it goes inwards. So there's a 5-point sensor inside of this, and you can actually basically use it as a tool for strengthening your pelvic floor. Like I said, I don't see a ton of hypotonic pelvic floor, but it is definitely something to do. It's basically like a trainer for your pelvic floor. Okay, so next, like I said, they're superficial pelvic floor muscles and deep. I showed you some of the deep muscles. Some of the more superficial ones are the bulbospongiosis and the ischiocavernosus. And a lot of times there will be perineal pain in between the vagina and the rectum. That's transverse perineal muscle. Okay. So what is vaginismus? Vaginismus can be primary or secondary. When a young girl who is now trying to learn how to put a tampon in and cannot get a tampon in, it's not because she's, 13 or 12. It's because normal women or girls are supposed to be able to put a tampon in without any trouble. So sometimes when a woman or a girl is now contracting her muscles, they can't get the tampon in. And the problem with being BASI is that mentality of, if you put a tampon in, you will lose your virginity and you will no longer be suitable for men. And because of that, many girls, BASI girls, or Pakistani Muslim, Indian Muslim, I want to say it's Muslim, but it's not even Muslim, because, they have tons of Christian women and Jewish women with vaginismus who come in, and they have the same issues. They can't get it in, and that's called primary vaginismus. Secondary vaginismus is when now they used to be able to use a tampon, and now they're having trouble putting it in. And when I say tampon, I also mean intercourse with penetration. So when women are young, that's primary. When it's secondary, it's when now they have had no problem in the past, have had penetration and, you know, good intercourse, and now they're having pain. So some of the causes, sometimes it is endometriosis, sometimes it's PCOS, sometimes it's trauma, sometimes it's abuse, rape, and even menopause. So, you know, a lot of times doctors will tell patients, just relax, use lubrication. If they drink alcohol, drink some wine. But that's not obviously a solution. Those are not, you know, if you actually have tight constricted muscles, it's like walking around like this all day. You're not going to be able to pull your muscles apart if they're just chronically tight and constricted. So, you know, for doctors, if doctors are watching this panel, you know, you should be able to speak to your patients about this, because it's very difficult for men and women to talk about the pain with sex. And, you know, for women especially, you know, we want to be able to have an eye-to-eye open conversation with our doctors. And often, if they don't feel comfortable, they're not gonna bring it up. But just today, I had 3 new patients with pain with sex. And so, you know, I have this conversation every day, and I ask questions so they feel like it's not an awkward conversation. So I think that's really important that you bring it up, because sometimes patients are just not going to bring it up. They just don't feel comfortable. So this is how we were talking about primary vaginismus. And so I didn't mention fibroids and adenomyosis, which is similar to endometriosis of the uterus. Other causes was the anxiety, strict sexual upbringing, and strong family religious overtones, and the fear of first-time sex or an STD. So a lot of people think that it's normal to have pain with sex, and it'll get better, and it'll get better, and it'll get better. And similar to a patient I had today, she said, "Oh, you know, after 2 years, I realized it's not getting better," and that's a matter of, it's just a matter of fact. And you know, you shouldn't give up on it. So many people are married for years before they can have sex, and it's unfortunate if they're not seeking help. You know, but that's why as physicians we're here to help our patients. And I actually encourage all of my patients to try using tampons. There are organic tampons if that's the concern, but you know, talking to your patients about the myth that a hymen is, you know, your virginity is dependent on a hymen is important, because obviously the hymen can stretch out just by sitting on a bike. And so that myth has to be debunked. So, you know, these are just more, many Daisy mothers, I talked about this. The hymen is a thin permeable membrane at the vaginal opening. Gymnastics, horseback riding, biking, Pilates, and even yoga can, you know, you won't necessarily bleed from any of these activities due to your hymen, and breaking. And then tampons, like I mentioned, the Lola and the Cora are also some organic options. And honestly, that's kind of, I feel like the problem is that so many women don't realize they have a problem until much later, because you know, we're taught not to experiment and not to do anything. And you know, religious wise, that's obviously important, but you know, a tampon is a nice way to not encourage necessarily experimenting, but to do some as a good indicator of how your pelvic floor muscles are doing. And you know, just because one sister in a family has children and the other sister doesn't, you know, that's sometimes I see a lot of where families where people blame that on the daughter. There must be something wrong with her because she's not able to have children. Oh, and there's a lot of family members where they make fun of their sisters for not being able to have intercourse. Oh, that can't possibly be. It can't possibly be your muscles, or it can't possibly. And you know, it's just not. You know, because primary vaginismus is actually a real condition, and it's not something that should be made fun of. Okay, so yeah, more of the same thing. The assumption is that intercourse is painful, and that's not always the case. And then that it's the pelvic floor is just tensing up prior to anticipation. So a lot of it becomes a vicious cycle of anxiety leading up to pain. And then now every time they are anticipating sex, it becomes more painful because they are more anxious. And so oftentimes I do have to talk to my patients about how they're going to deal with that anxiety, whether it's going to sex therapy, whether it's going to cognitive behavioral therapy, whether it's taking an anti-anxiety medication. And there's other things that I'll mention later on. So secondary vaginismus, which I alluded to previously. So menopause, infectious, traumatic events. I had an interesting scenario with a patient a while back. She had been married, was happily married. Her husband died tragically at the age of 35, and she had no intercourse for another 15 years. When she finally met someone she wanted to marry, they got married, and then she was not able to have penetrative sex intercourse because it was too painful. And we worked together so that she could, because that was important for her, and intimacy. And obviously in a lot of marriages, most marriages, intimacy is very important. So that is an example of secondary vaginismus. Okay. So treating it, the most important thing is not trying to force intercourse. I've had a patient tell me once that her mother locked her into a bathroom and forced her in and said, "Don't come out." Now, these are not necessarily good techniques, because she created all this trauma regarding a tampon and said, "Don't come out until this tampon is in, because when you want to have sex at some point, a man is going to be bigger than this if you can't even get a tampon in." And so that's absolutely insane, because the trauma that she has created now associated with sex and with tampon use is like quadrupled unnecessarily. So pelvic physical therapy is definitely something that I would recommend. As a physiatrist, I am treating patients with, I'm a rehab doctor, so all I want to do is see patients rehabilitate. So with pelvic physical therapy, it is one-on-one. Depending on where you are in the country or the world, you may not have access to it. And for I have many people who reach out to me on social media. Often I tell them there are books that you can learn about pelvic rehabilitation, such as Heal Pelvic Pain. It's a little bit difficult to do pelvic therapy on yourself, though. It's like giving yourself a massage. You're not going to be as good as if someone was in there themselves. Now, that being said, you have to make sure you're going to the right person, someone you feel comfortable with, because they're going to be inside of you. And it's definitely a little bit difficult to deal with if you are very, very uncomfortable with that situation. Most of the time, they will do some external work and work on your adductors or on your core muscles, and try to loosen up those muscles before trying to loosen up your pelvic floor muscles, only because they're all connected. Just like your adductors, which are right here, and your piriformis muscle, which goes from your hip down inside your pelvis, and your pelvic floor. There's no delineation. There's no line saying this is the beginning of your pelvic floor muscles, this is the end of it. So when your core is tight, it's just like the addition to your pelvic floor. So stretching those out and working on those all together help significantly. So that myofascial release is important. So they'll also talk to you about different tools that you can use, dilators and wands, and I do have them here. So let me bring that slide up. I'll show you some. But pelvic physical therapists can be your biggest ally. They can teach you things. They can teach you things about intercourse that you may not know. I had a 50 or late 50s-year-old woman she was in her mid 50s, and she had never been penetrated in 30 years, or she comfortably. So maybe once or twice in those 30 years, but she never enjoyed intercourse, and her and her spouse always found other things to do because she could not tolerate penetration. But after a couple of months of after talking about going to physical therapy, the things that she learned there. So she herself does not know much about sexual education because she's in her 50s, and 30 years ago when she was in another country, a foreign country, they didn't teach sex ed. And so there are a lot of things that you can learn from your pelvic physical therapist, which is why I highly suggest anyone who's able to go. There is a website called APTA, and you can search for under women's health where there is a pelvic physical therapist near you. Obviously in the US, in New York City, there's like 5 on one corner. But you know, in other outside of New York, there's probably maybe 2 to 5 in maybe even any given state, maybe 1 or 2. So that's not exactly accessible for everyone. But that being said, there are some tools that I'm going to show you that hopefully that if you know of patients or patients need help, they can at least start using some of these tools. So vaginal dilators. My favorite vaginal dilators are these intimate rose ones. The ones that I have on the screen are the sole source brand. Patients typically like silicone dilators better because they're bendable and they make it a little bit more lifelike. And as well, nobody wants to put plastic inside of their vagina. So these dilators, you really don't want to, you don't need to get necessarily, if you have one single partner, you don't need to get anything more than the size of your partner. So, you know, they can be kind of daunting and a little scary. And so the goal of them is to stretch the vaginal entrance. Now, this typically helps with entrance pain. However, it can also help with penetration pain. So as it sounds like, this is to help enter. And then obviously when there is penetration, hitting the back of the muscles or hitting some of the muscles back here, there are different tools for that as well. So I'll show you that in a second. But yeah, this is the Intimate Rose brand. The Sole Source brand is another brand that has the silicone, and there are multiple other brands that have plastic ones. The plastic ones are a bit cheaper, but you know, if you're not able to do physical therapy, I would probably suggest spending a little bit and getting the silicone because they are a little bit more lifelike and less painful or uncomfortable. The pelvic wand, I actually only have this wand. Someone took my purple wand. I don't know where that went, but the acrylic Therawand is when patients are able to now have successful penetration entrance, but they are now having penetration pain. You can actually work out the muscles in the back. And so this tool, it's like massaging yourself. It's essentially, you want to be gentle. Now this is glass. This is why I don't love this one, because you can hurt yourself. And I've had a patient or two who has not been super gentle and has hurt themselves. But that being said, if you're a little light-handed and you need a little bit of heavy-handed, this could be helpful. Obviously, I always say go to pelvic physical therapy, but if you don't have the access to the pelvic physical therapy, this is a tool that could be used at home. The Intimate Rose one, the purple one, is actually much softer because it is made out of silicone on the outside, and it's a little bit longer, so it's easier to get in and a little bit more ergonomic friendly. There are other brands. If you search pelvic wands, you could probably find a couple. And then the purple one also comes in like a vibrating one as well. Honestly, I don't think that's not necessarily necessary, but if you've ever used the TENS unit where you feel that vibration, and sometimes that can actually help loosen up the muscle as well. The O-Nut, I brought the O-Nut today because I wanted to show everyone this because it's one of the first tools that is actually was just created only a year ago. It's basically a tool for penetration buffering. So if you imagine this is at the base of the penis, and I tell my patients, this would be very odd if you had multiple partners, but if you have one partner and your partner doesn't mind using it, now it's a buffer. And so basically you're not hitting those muscles that were potentially being hit before. This is not a treatment. So the good thing about this is you can add. So if your partner is a little bit longer, you won't hit. You can subtract. You can take away one of the rings. But like I said, this is not a tool. This is not going to make things better. You're not going to make your pelvic floor better, but this is a means to an end. So if someone wants to have a baby and they need penetration, this is definitely something that when it's also condom compatible, it's also, lube friendly. And yeah, so it's called the ONUT. It's actually pretty good for people who need to get certain things done and they're not so concerned with necessarily treatment, or they just want intimacy in their relationship. Okay. Other treatment options. So magnesium is a good and underrated muscle relaxation vitamin. It also works well for your bowels. And so when people have chronic constipation, they're now straining and pushing on their pelvic floor all the time. So when that's happening, they tend to make their pelvic floor even tighter. So this is actually, I take magnesium every day because it helps with my bowels, and I think it's good if you're not eating a good diet filled with a lot of vitamins, and having magnesium is good. Also, Epsom salt baths are good to relax your pelvic muscles when you're in, there's magnesium in the salt, so you can absorb it. Vaginal or rectal Valium suppositories is something that I prescribe. It's a prescription suppository, and it actually is really good because it is compounded by a pharmacy. It has Valium, and I compound it with baclofen, which is a muscle relaxant. Patients can put them in vaginally or they can put them in rectally. Vaginally, there's a little less systemic absorption. Rectally, there's a little bit more systemic absorption. So for these patients, they can, you're not going to feel loopy like you would if you were taking it orally. However, you may wake up a little groggy if you are using it rectally. That being said, for vaginismus, obviously, it would be good to get it inside to the superficial and the pelvic floor muscles over here. And then trigger point injections. So I do trigger point injections in my office for the pelvic floor. I go externally. I don't go inside the vagina, and I don't go inside the rectum, and I trigger point all over the pelvic floor. And so I'm also blocking some of the nerves of the pelvic floor. So for those who are physicians and watching and may have interest, the major nerves of the pelvic floor is the pudendal nerve. It has innervations to the dorsal nerve of the clitoris, the perineal branch, and the rectal branch. You can see all the reds and blues, arteries and veins, and there is that blood supply. But the pudendal nerve is one of the major nerves that I'm blocking, as well as the inferior corneal nerve, which is a branch of the posterior femoral cutaneous. Just really quick, the bowels. I tell my patients I want to see lots of logs. I don't want to see pellets, because when you have pellets, you're constipated, and then you could potentially be making your pelvic floor even tighter. And going forward, you can have hemorrhoids and fissures and all stuff that make not good pelvic floor situations. Okay, and so I did say I would talk about chronic pain and how this is all related. When patients have certain issues like vaginismus, or they're chronically in pain all the time due to anything, whether it's endometriosis, whether it's PCOS, or whether, something's causing pain, or they fall on their tailbone, their muscles go into spasm, there is a decrease in circulation. I don't know if this is my next slide. Maybe not. And what happens is the muscles are weak, the pelvic nerves are now irritated, and there is some central sensitization, which is just a simple way of saying your brain does not, your body now thinks this is your new normal, and your brain and spinal cord are now super sensitized and thinking that this is your normal, and it doesn't have the same response as if you weren't in chronic pain. And so I often use a lot of medications depending on the person, not necessarily for vaginismus, because typical vaginismus patients don't have pain all the time, they just have pain with sex. And so those people who are having chronic pain, SNRIs like serotonin norepinephrine reuptake inhibitors, tricyclics, and membrane stabilizers are super helpful for mood, anxiety, depression. But if they're a young girl who may or may not, necessarily need to be on a pain medication, I would consider an SSRI, just because of the risk of pregnancy. But those are typically the medications that I use. Alternative treatments, acupuncture is great. Acupuncture is just improving the blood flow in the pelvic floor. If you find an acupuncturist who will work around your perineum, that can help relax your pelvic floor as well. Craniosacral, which is osteopathic manipulation, yoga, movement specialist, meditation, and sex therapy, cognitive behavioral therapy, which we kind of mentioned. And then also, if the patient has a history of trauma, maybe eye movement, desensitization, and reprocessing, as well as OCD clinics. So let's get into endometriosis. So endometriosis is, by definition, when a tissue that's similar to what is in the endometrium, but not in the endometrium inside of the uterus, is now found outside of the uterus. So it's not the same thing, but it looks like it is, and it's tissue. And it's now hanging out everywhere except inside the uterus. And it could be on top of the bowel, it could be on top of the bladder, it could be sitting on the diaphragm, it could be anywhere. Essentially, it's a benign cancer, and it spreads. It's not like cancer because you're not going to die from it, but it's benign, and unfortunately, it causes a lot of pain. And 1 in 10 women has it, which is really scary because that's a lot of people. And unfortunately, it's not being treated and not being aggressively researched because it's not necessarily going to kill you. So 176 million worldwide are affected. It takes about 7 to 10 years for diagnosis, mostly because so many different, systems are being affected. So GI symptoms, you may present with abdominal bloating, chronic constipation, maybe alternating diarrhea, constipation. And so a lot of people are thinking IBS or thinking colitis or, hemorrhoids. And then they might also present with urinary frequency and urgency. So they are thinking UTIs, and then maybe interstitial cystitis if they're talking about burning, or bladder pain. And the overlap in symptoms quite often makes it missed as a diagnosis. GYN conditions, a lot of people are thinking, is it fibroids? Is it, could it be like a cyst? Or is just ovarian cyst bursting? And endometriosis is now found in 9% of female fetuses, so we know that it is genetic. Whereas previously there was a different theory that it was retrograde menstruation, and now that theory has been debunked. So symptoms, many girls, 13, 11, when you first get the period, I had one patient with endometriosis today, and she had debilitating pain on the first day of her period. Any girl that needs to miss school or work because of her pain, that's not normal. If she's ever in the ER because of the pain, that's not normal. If she's got vomiting because of the pain, or she's ever close to passing out because of the pain, that's not normal. If you ever see her on the floor, that's not normal. So patients will also present with, and it's not necessarily limited to the 5 days of their period. Sometimes it is, sometimes it's the first day, sometimes it's the second, sometimes it's the whole week, then it's 2 weeks, maybe it's 3 weeks. And that's also why sometimes it gets missed, because sometimes it's all month long, and patients, doctors are not able to figure out how it's correlated to the menstrual cycle. Many times, like I said, presents with frequency, urgency, or burning, chronic constipation, endobelly. That abdominal bloating is when you look like you're pregnant and you're not pregnant, and then it resolves, but then it comes back and then it resolves. And if you actually, look at, hashtag endobelly, you'll actually see women who literally look like they're pregnant, like 5 months pregnant, but they're not. And then, like I said, most people will sometimes often go to the ER, and there are different severity and grades to endometriosis. And so sometimes when you hear of a woman who's got painful periods, but it's not that bad, you think, well, she can't possibly have endometriosis. It's not that bad. She doesn't go to the ER from it. But that doesn't mean she doesn't have it. That just means she might have a lower grade, but the symptoms and the level don't always correlate of the grade. But usually the symptoms are worse when they do have their menstrual cycle. And so the reason endometriosis is bad is because it's an inflammatory disease that affects the scar tissue and adhesion formation inside the abdominal and pelvic cavity. It attaches to the organs and the muscle and fascia, which makes it really difficult because now your pelvic floor muscles can be tight and cause that hypertonicity. They're also tight in their core because when you're in pain, you tend to clench your abdomen, you tend to clench your pelvic floor, and there's a lot of guarding, which causes more pain and tension. And this was the chronic pain cycle that I mentioned earlier. And so you can see how a woman with endometriosis would eventually be sensitized and upregulated. And so this was just a slide of how I do blocks. When I do ilioinguinal and iliohypogastric nerve blocks, when women have pain in their ilioinguinal region, I use ultrasound guidance. Everything is from outside. So the issue with endometriosis is diagnosis is very difficult. Why? Like I said, 5 to 7 years, because ultrasounds don't always show it because it's tissue, right? So it's not necessarily seen. MRIs don't always 100% show it. There's like so many doctors who say like, oh, the MRI was negative, you don't have endometriosis, you're good. And that's the end of it. But that doesn't necessarily mean it because number one, it might not be a good image. Number two, unless it's deep and infiltrative, it might not show up on imaging. And it's also dependent on the radiologist reading it as well. And like I said, stage is not always equivalent to severity. And obviously, if you're diagnosed much earlier, your quality of life will be better. I've seen many, many, many girls who have not been able to work, go to college, get married, have lost their eggs, lost their uteruses, hysterectomy secondary to endometriosis, which is not a treatment because, like I said, endometriosis is not in the uterus, it's outside of the uterus, so a hysterectomy would not treat it. So the gold standard is laparoscopic surgery with pathology of the lesion. And unfortunately, nobody wants to have a surgery to diagnose endometriosis, but most of the girls and I've seen with endometriosis are desperate for a diagnosis and will go under the knife to have a diagnosis. But the problem is that if you have the wrong surgery, if you have an ablation, what happens is it's burned off, and so you're not going to have anything to send to pathology to diagnose it. And so excising is the gold standard for treatment, and that's actually digging out and cutting out the endometriosis. There is a current study in place called the ROSE study that Lenox Hill Hospital is doing to use menstrual blood to diagnose endometriosis. To be honest, I have no idea how long that's going to take because they need studies, and typically women with endometriosis who are feeling well don't have uteruses and hence aren't bleeding, or aren't able to put anything into their vagina because it hurts too much to give a blood sample like a tampon or a menstrual cup. So fertility, how does this affect women? 40% of unexplained fertility is due to endometriosis. So that's called silent endometriosis. I don't know, I think I skipped over it when I said endometriosis is previously considered a white woman's disease. So apparently back in the day, only white women were able to afford to get treatment for endometriosis. And so they thought it was a white woman's disease because no one else was claiming to have any painful periods or pain in general. And that's pretty unfortunate. So silent endometriosis, there is the trend now is for women to get married, they may become sexually active in their teens or their 20s and they go on birth control. And then in their 30s, now they're meeting people, they're coming off the birth control and they're trying to have babies. And they're now realizing, oh, one, I have pain with my periods. And then two, why am I not getting pregnant? And they find themselves infertile and going to a reproductive endocrinologist and now trying to figure out why they're not getting pregnant. And they find that they have endometriosis. So with some of these women, it's called silent endometriosis. And that's obviously not everyone, but that there are a good chunk that have clinically less severe stages of endometriosis. And then endometriosis forms adhesions around the ovaries and tubes and blocks the eggs into the tube. So that's another way endometriosis can actually prevent fertility or baby making. Ovarian chocolate cysts, they also destroy the ovarian tissue and decrease egg quality. So I always tell my patients, I always say the F word, fertility, because I think it's really important. Anyone basically after 25 should understand that if you do have these painful periods and it may not be worth having a surgery to diagnose endometriosis, to at least consider fertility, because when you are now in your 30s and trying to get pregnant or getting married and then maybe getting pregnant in your late 30s, it becomes much harder when your egg quality is not that great, especially after 30 when your egg quality declines anyway. So one of the risks, however, is egg freezing. One of the risks of egg freezing is actually aggravating your endometriosis, because of all the hormones that go into freezing your eggs can actually really set off a patient's endometriosis, because endometriosis is hormone dependent, estrogen or progesterone. Endometriosis decreases IVF success rate until the endometriosis subsides. So just today I was talking to our physician liaison, and she said that she had recommended a friend who has continuous miscarriages over and over again, and she had recommended the patient go see an endometriosis excision surgeon. The endometriosis was excised, and now she is pregnant and carrying to term. So the risk of miscarriage becomes as high as 50% with endometriosis. And the treatment for this, then there is now a large amount of people who are talking about endometriosis in commercials. When you're watching Channel 7, I often see commercials for endometriosis. A lot of the commercials are from pharma, because they're the ones who can afford to so I have like no disclosure, so I don't take any money from pharma, but pharma, the birth control and a lot of the medications that are used to put people into menopause are treatments for endometriosis, because they can help decrease the estrogen and relieve symptoms. However, it's not necessarily a treatment if there is endometriosis growing continuously. So excision surgery, though where it may not be accessible to everyone, excision surgery is obviously gold standard. However, if you can't afford it or you have no access to it, many patients are on birth control or on medications to put them into menopause. There is a higher recurrence rate with ablation surgeries, like I had mentioned earlier, and up to a recurrence of 80%, and when with excision the recurrence rate is 12%. So obviously excision is ideal. Research suggests long-term use of oral contraceptives or IUDs that may reduce the recurrence of endometriosis postoperatively. So after you've had it excised, if you put an IUD in, that can actually decrease, that can actually improve your pain and decrease the recurrence, which is why so many people want to do it, although a lot of women don't like to be on hormones, and so that is always an option as well, but then there is that recurrence rate. And then needing another subsequent surgery. And so what I do with women who have endometriosis, a lot of what I do is treating their pelvic floor, because if you treat their pelvic floor, you can treat their dyspareunia, their painless sex, you can treat their urinary symptoms that are irritated because of their endometriosis on the bladder, as well as their bowel symptoms. So, fixing their quality of life, it may not necessarily remove their endometriosis, it can help with some major functions of their quality of life. Vaginal or rectal Valium can relax the pelvic floor. It also gives pain relief for a lot of women. It helps with their chronic constipation and decreases urinary frequency. The neuropathic medications I had mentioned previously, like SSRIs, SNRIs, and neuromodulators also help. I typically don't give out opioids to any of my patients. only because that they do tend to help with pain, but they also constipate patients and then make their pelvic floor worse. And then medical marijuana is an option for patients who need either additional help or who don't want to take opioids or take neuropathic. So some basic myths about endometriosis: that hormones are a cure. Nope, hormones are not a cure. Like I had mentioned, there is no cure for endometriosis, unfortunately. Pregnancy is not a cure, though for many women, their mothers or grandmothers may say, oh, after I got pregnant, I felt so much better. That may be the case, but that does not necessarily mean it's a cure for pregnancy. So telling a patient, just have a baby, you'll get better, that's not always going to happen. A hysterectomy is not a cure, similar to what I mentioned before. Removing your uterus because you're desperate does not mean that it will go away, especially if the endometriosis stays in your uterus. In your pelvis. And then same with taking out your ovaries, because a lot of people are in so much pain, they get so desperate and they want to take out their uterus, take out their ovaries, but that now puts you in menopause and gives you a whole subset of problems. Pregnancy, that's the same one. And then having endometriosis does not mean you can't get pregnant. You can certainly get pregnant, like I had mentioned. It's just a matter of making sure your egg quality is good, making sure that things are not blocked, and that it's a more hospitable environment for your fetus to grow. And then endometriosis is not just a painful period, so it is a debilitating. It is multi systemic disease. It's not just one system affected. And then barriers with it, diagnostic delay, which I had mentioned, unfortunately through imaging, cost of excision surgery. Excision surgeries are much more costly compared to ablation surgeries because the coding in the US is the same. However, the amount of time it takes to do an excision surgery is much longer than an ablation, as an ablation is just burning and excising is taking out. So quite often doctors who can do excision surgeries do go out of network or don't take insurance at all. And then the lack of knowledge among physicians. I'm a physiatrist and probably one of the few pelvic physiatrists in New York or throughout the country that actually do pelvic physiatry. Most people don't even know what a physiatrist is, a rehab doctor. But that being said, even amongst your urologists and GI doctors, I would really, really, really hope that most GYNs know what endometriosis is. But it quite often gets missed, and I think if more doctors who put together and stood back and figured out, the symptomology and how they can relate, it's just asking a couple extra questions, patients can figure out that, we can help benefit a lot more patients by understanding that this is multi-systemic. And that's it, just under 1 hour.
No, that's great. No problem at all. No, thank you so much, Dr. Ahmed. That was extremely thorough and very detailed, and so we so appreciate you going through all of that. We actually do have a few questions. Questions, so I'll go ahead and start asking them. So the first question we got was, should everyone take the measures to prevent entrance or penetration pain even before having intercourse?
Yeah, I don't see why not. I mean, I actually was joking with a patient that this is like a great bridal shower gift, because, it's like, why do you want to have painless sex? And you don't know if you're going to. And so, if you're not using tampons prior to intercourse, you're not going to have any idea. I mean, you don't know how many girls I see who are like, oh, I got married and now I'm trying to have sex and I can't. No one ever talked to me about it. I never got any sex ed. So even using dilators prior to intercourse isn't a bad idea. And I tell patients, if you're having pain with these, don't try to have sex until you're able to get to the size of your partner. Like if your partner is this size and all you're able to get in is this size, well, don't try to have sex then, because it's going to hurt and it's going to make you feel sad and depressed, and you're not going to want to have intercourse, and it's going to create a lot of anxiety and pain and fear.
Okay, great. Thank you. The second question is, if you have debilitating pain on the first day of your menstrual cycle, which to the point where it can cause you to miss work, but none of the other symptoms that you had mentioned about endometriosis, is it still possible to be endometriosis?
Oh, definitely, 100%. Just because you don't necessarily have chronic constipation or, abdominal bloating doesn't mean you can't. And the thing is that endometriosis, it usually is a bunch of symptoms, but it doesn't necessarily mean it's not, just one.
Okay, perfect. And then the third question was, is it possible to develop endometriosis later on in life? For 8 years, I had almost painless periods, after which I started to have extremely painful ones. It has been 5 years now with this pain, especially on the first day of the cycle.
Yeah, so definitely it could have been silent for a really long time. It also could be progressively becoming stage 1 to 2 and now starting to become infiltrative.
Okay, and then this is just a question off of that, is that who do you recommend that people reach out to when they do have these pain? Is it something where they should go to their primary care, or should they just refer themselves to someone like you, like a physiatrist?
No, I mean, honestly, there's not a lot of physiatrists in the country that do this, so it depends on where they're at. I mean, obviously, if they're in New York City, happy to see them. But if they're hanging out in, I don't know where they are, but wherever they are, it may not be easy for them. So I would really advocate and tell your GYN and say, listen, I think I have endometriosis. Do you know endometriosis? Do you know an endometriosis specialist? A lot of GYNs, unfortunately, if you're in a small town, are the only GYN who's also delivering baby, who's also doing pap smears, who's also doing, taking out fibroids. And you can't go to someone who just does that, because endometriosis is so difficult to see because it's a tissue. It doesn't have like a sign on it that says this is endo. It doesn't necessarily show up as black or brown. It looks different for different people and different areas. And so if you're not an endometriosis surgeon and you're not taking it out all day, every day, then you could totally miss it, in which case it would be a waste of having that procedure. So there are a lot of, if you have endometriosis or you think you do, I would say join this group called Nancy's Nook for Endometriosis Education. It's on Facebook. It's a really good educational resource. It is not a support group in any way, means, or form at all. So don't think of it as a support group. It's just education. And when I say, they can be kind of mean in that group because they want you to get help and get better. They're not looking to hold your hand. And so that group can teach you a lot about the disease. It can teach you a lot about the doctors available. They have Nook doctors that are all over the country that can help you, and even all over the world. I think they've compiled a pretty significant list of doctors. I want to say there's some in like London and Pakistan and India, and so a lot of people travel pretty far for the right doctors.
Yeah, could you repeat the name of that Facebook group?
It's Nancy's Nook for Endometriosis Education. There's a lot of groups. There's also a book called Beating Endo. It's called Beating Endo by Iris Orbuck and Amy Stein. One is an endometriosis surgeon in California who previously worked in New York City. And she just, she still works. So we work, sometimes we have mutual patients, but she just moved out to LA about a year ago. And Amy Stein owns Beyond Basic Physical Therapy in New York City. And they wrote this book together. It's a collaboration of how to treat and beat endometriosis pain. They talk about diet, they talk about exercises, they talk about different things that you can do, different ways to change your mindset, and how to approach doctors and how to talk to doctors about it. So it is definitely a really good resource as well.
Okay, awesome. I'm going to hand it over to Dr. Khan, who's the chair of our education committee.
Assalamu alaikum, Dr. Ahmed. Jazakallah khair. Thank you so much for your talk. I know we're hitting 8:30. I do have maybe two questions if you have a few extra minutes.
Sure. Yeah.
One was in regards to your discussion on primary vaginismus. You talked about some of the cultural implications in regards to its connection. And so I was looking for what you think that can be done in order to fix that, or in order to bring awareness to this. Is it something in which, our religion or our faith in Islam is something in which intimacy is something which is encouraged. It's considered to be an act of worship. It's not considered to be something which should be shunned. And there are a lot of cultural stigmas and implications in regards to how one can, deal with their period, not just pads, but there's even hadith that talk about, a woman who came to the Prophet ﷺ and said, I have a strong menstrual flow. And he said to her, this is in Ibn Majah, block it with cotton. In other words, saying, essentially in modern terms. And so it's something interesting culturally, this contradiction in that way. So just, a little bit of your advice in that regard from your professional standpoint, and also just any psychological forms of treatment in regards to sisters that we may know who are dealing with primary vaginismus as a result of growing up in that kind of environment.
So because I've seen, the reason when I started doing this, the reason I started becoming more vocal on social media and reaching out to different groups and talking to different groups about this was because I wasn't seeing a lot of Desi, Pakistani, Indian, Muslim, Bengali, Muslims all over the world, African American Muslims, there were Africans and there were Caucasians, but I wasn't feeling like I was seeing any Muslims. And I have two daughters, and so growing up, I thought, my vagina was, and my shame. And so I wrote an article for Brown Girl Magazine and Muslim Girl Magazine, or whatever, the online magazines, that basically saying, like, do you call your vagina, or do you call your vagina your shame? And obviously there are all these like taboo topics. My husband, like, he's like, why do we have to say the word vagina? Because he's a man. But that's like propagating the whole stigma all over again, because we're too scared to use proper terminology. My daughters have seen me put a tampon in. They've seen me have my period. They're only 5 and 6, like, they're young. But I never saw my mom ever talk about it. When I got my period, it was like, here's a bag of pads, and that was the end of it. My conversation about periods was through my aunt, and my aunt said, do you know what a period is? And I kind of pretended, because I just knew that it was going to be awkward. I think talking about it, I think the way we can change the next generation is by talking about it early, with our daughters, if you have nieces and your family members are uncomfortable with it, you have to take it upon yourselves to educate the next generation, because it's only going to, I think we're in a different situation where we're now first generation Americans, where we are here and we have the opportunity to make it less weird, where our parents came here and they had no idea what was going on, and they kind of were really weird about a lot of things. We learned everything on the school bus, and now our kids are going to learn everything on social media. So if we don't take it upon ourselves to educate, they're going to learn about it on social media by the time they're 6, because they're all on YouTube right now, and they're all watching YouTube, and we don't know what they're watching. So, obviously we should be watching what they're watching, so they're not watching weird stuff. But I think it's very important that we educate the next generation. And then in terms of, not feeling that stigma, getting help and feeling like, there's nothing wrong with therapy, and there's nothing wrong with sex therapy. There's nothing wrong with listening to podcasts about sex. And a lot of like Muslim girls have asked me, like, they've asked me, like, what is appropriate? Like, what kind of intercourse is appropriate? And, as a doctor, I feel like I'm okay talking to them about that, but not a lot of doctors have an hour to chat with their patients about intercourse and, talking to because a lot of people don't talk to their friends about sex, and does it hurt? Does it not hurt? Do you feel like your husband's happy? Do you feel like, we only have sex once a week, once every other week? These are, they're growing up, I remember going to a class, an Islamic class, and I don't even know if I was supposed to be there or if it was like my mom's class, and the person said, maybe you can tell me, oh, you're not supposed to, the only reason you should have sex is for making children. And, that obviously stuck with me. And, a lot of Christians believe the same thing. I mean, Catholics, I think, believe the same thing. And, that stigma that intercourse is only for child making and not necessarily for, my daughter's right here, necessarily for your pleasure. And so having these conversations that it is for pleasure, it is okay, and it's not a terrible thing. And I put myself out there like all the time posting about it on social media, and obviously husband's probably really uncomfortable with it, but I don't care because it's benefiting some other people.
Thank you so much for that. I mean, many of us have benefited in that way of being able to learn it in a private, comfortable setting. I mean, we're moving towards a community being able to talk more openly about this, but, there is an element of being able to learn at the same time within this element of privacy, such as a webinar. My last final question that I had was, you briefly mentioned a little bit about pelvic pain for men. Could you go into that just briefly? I'm just personally curious in regards to, men who are married and maybe dealing with that. And we know that that's something that can happen with women, but, for men who may fear being able to talk about that, or the quote unquote, worried about not doing his husband duties or not being able to, perform sexually as a result. What is your, professional understanding of why that happens or how they are to deal with it?
So for men, it's a little bit different, because for men, it could be overutilization of muscles. So in basic terms, they can have created some trauma after masturbating. Their friend could have hit them in their testicles. They could have created pain. So typically they present with similar symptoms. I didn't get into too much of the female other symptoms like vaginal burning, vaginal itching, vaginal discharge, that are not sexually transmitted diseases, that are just good old, vaginal or vulvar burning, vestibulitis, vulvodynia, which are other conditions, because I kind of left it to endometriosis and vaginismus, but there is conditions called vulvodynia and vestibulitis, which is essentially having pain within. So a lot of people see this and they're like, this is the vagina. So if you know your actual parts of the vagina, there's the labias on the outside, and then there is the vulva, and then when you're inside, it's the vagina, and there's the cervix. And so anything with that is basically, when it's inside, it can cause pain and burning. And so some women can have pain all day long, where they're having burning 24/7, and it's not necessarily with intercourse, and intercourse can actually aggravate them. Similarly, with men, they can have pain in their perineum, which is, pretend this is a penis. They have pain between their penis and their rectum. They can have pain in their rectum. They can have pain in their testicles. They can have pain in their penis. The tip of the penis is the dorsum. They can have pain in their groin. There could be a hernia, inguinal hernias which are now going into their penile and to their genitals, can be irritating their ilioinguinal nerves. And then because of that, their nerves are inflamed, their pelvic floors are on fire, everything is tight, similar to women. And so because of this, they can have pain after ejaculation, they can have pain during intercourse, they can have pain all the time, they can have pain when sitting, and they can also present with the same urinary and bowel issues like chronic constipation and urinary frequency and urgency. So for men, it's the same kind of treatment, because their pelvic floors are basically the same. The pelvis is a little bit different, but, relatively the same. You can have pelvic physical therapy. You can do rectal Valium. You can do oral medications. You can do trigger point injections, nerve blocks. You can do manual massage. For the guys, there's actually a different wand, which I didn't bring today because I was doing a female one. They can use rectally, because when they do PT, they're going in rectally with their finger to manually work on it. And then similarly, there's a wand to go in rectally as well. And this is all non-pleasure, not sexual. It's uncomfortable. It's weird. but you get used to it. And most of my patients who do have pelvic physical therapy and then use their wand and use the Valium, they feel like they've found treatment, because now they're not living with chronic pain and neuropathic pain. If you've ever had neuropathic burning, zaps to the penis, or zaps anywhere, if you've had zaps, imagine having zaps to the penis or to the testicles. It's very uncomfortable and debilitating for men as well. So although I feel like women are always not, treated equally to men, in this, I have a soft spot for the male pelvic pain patients, because they're suffering just as well as women.
Yes, thank you so much for letting us know. It'd be something in the future, be able to hold a webinar for the male pelvic pain, so that way that we can have an outlet as well. But I will pass it over to Mariam to see if we have any more questions. But just so for those who are listening, I will link or post the resources that Dr. Ahmed had mentioned in her talk, so that way if anyone is interested, they can check them out. But I'll pass it over to Mariam now.
Yeah, no, thank you, Dr. Khan. So again, I just want to echo what Dr. Khan had said. Thank you so much, Dr. Ahmed, for your time, for your expertise,
no problem,
for really breaking down the stigma about pelvic pain. So we have no further questions, but just kind of wrapping things up, that this webinar again is recorded, and so we'll inshallah send this out via social media as well too, so that people can view later on as well too. And if you have any ideas, any thoughts about either future topics and future ideas for how to keep this conversation going, or in your community, or however format you prefer, please let us know. Please reach out. And again, we're going to be staying in touch with Dr. Ahmed, and hopefully be doing more webinars and more information about this material. So thank you so much again, and I hope inshallah everybody has a great night.
All right, thanks so much.
Assalamu alaikum, everyone. Bye.
All right.